Hello friends, nice to see you again. Let's enjoy Dr. Y's chest radiology. I'm Dr. Y, medical professor, chest radiologist, Seoul, Korea. Today we're going to talk about the part 3 of Fleischner Society 2024 glossary of terms for thoracic imaging. Let's begin. This topic is based on the radiology, reviews and commentary, statements and guidelines, Fleischner Society Glossary of Terms for Thoracic Imaging by Alexander A. Benkier et al. Radiology 2024, 310. This topic is for you who want to know the definition of and the radiographic CAT scan findings of the thoracic diseases. Now let's start. Cavity. Pathology. A cavity is an abnormal gas or fluid-filled structure with a typically thick and often irregular wall, usually produced by expulsion or drainage of a necrotic part of the lesion by a bronchial trees. It may be isolated or associated with adjacent lung pathology, and a gas fluid level may be present in the cavity. Cavities are to be differentiated from pseudocavities. A pseudocavity appears as an area of low attenuation in the nodules, masses, or consolidations that represent spared parenchyma, normal or ectatic bronchi, or emphysema rather than cavitation. Cavity pathology. Arrows indicate the cavity of tuberculosis. Cavity pathology. Both arrows indicate the cavities in the lung cancer of squamous cell carcinoma. Cavity pathology. Pseudocavity. Both arrows indicate the pseudocavities in the ground glass nodule of adenocarcinoma. Cavity pathology. Pseudocavity. Arrow indicates pseudocavity in the ground glass nodule of adenocarcinoma in right lower lobe. Consolidation pathology descriptor. Consolidation refers to increased attenuation of lung parenchyma resulting from evacuation of air from alveoli and its replacement by fluid or other material. On radiographs, consolidation appears as a homogeneous increase in attenuation. At CT, it is defined as opacity causing complete obscuration of underlying bronchi and vessels, the latter only on unenhanced CT examinations. Patent bronchi within consolidation may form in bronchograms. The term is a descriptor that does not indicate the pathologic nature of condition causing consolidation. Consolidation pathology descriptor. The arrows indicate the right middle lobe consolidation on chest radiograph and a CAT scan. Consolidation pathology descriptor. Arrows indicate the consolidation in right lower lobe at CAT scan. Consolidation and ground glass opacity. Black arrows indicate consolidation and white arrows indicate ground glass opacity in right lower lobe of pneumonia. Cyst pathology. A cyst is any circumscribed and well-defined air-containing structure in the lung parenchyma Cysts can originate from mechanisms such as airway obstruction with distal airspace dilatation, check valve mechanism, necrosis of airway walls, or lung parenchymal destruction by proteases. A small number of lung cysts may be seen with aging. At imaging, a cyst appears as a circumscribed and well-defined radiolucency and/or low attenuation area with a thin and usually regular wall. Most cysts contain air, but they can occasionally contain fluid or solid material. Of note, radiologic and pathologic definitions of cyst differ. Cyst pathology. Arrows indicate cyst, lung cyst. On your right side, this patient is LAM, lymphangiomyomatosis. Cystic pathology descriptor. Cystic is descriptive adjective designating lesions characterized by central air equivalent attenuation, surrounded by a wall of variable thickness and regularity. There is an unavoidable morphologic overlap between structures commonly described as cystic, bulla, flap, cyst, due to lack of objective criteria to quantify wall thickness of these structures, and because of a multitude of currently proposed definitions, rather than a decisive consensus in the literature. As the cause of cystic lesions is often difficult to determine at CT, the term cystic can be used as a descriptor without implying etiology. Cystic pathology descriptor. Both arrows indicate cystic lung cancer. Both lesions are from squamous cell carcinoma of the lung. Embolism, embolus, emboli, pathology. Embolism refers to pathologic lodging of a partially or completely obstructing material, embolus, inside the blood vessel. The embolus may be a blood clot, i.e. a thrombus, fat embolism, air or another gas embolism, amniotic fluid embolism, infectious material septic embolism, neoplastic tissue tumor embolism, or a foreign body. On ventilation perfusion scans, areas affected by the embolism appear as a mismatch between BP scans with a ventilated perfusion defect. Partial or complete vascular occlusion caused by embolism may cause necrosis of lung distal to embolus, infarction. Embolism, embolus, emboli, pathology. White arrow indicates embolism in left lower lobe pulmonary artery branch. Black arrow indicates infarction area in left lower lobe. Emphysema pathology. Emphysema is characterized by irreversible enlarged air spaces distal to and originating from the terminal bronchioles with destruction of alveolar walls. The absence of fibrosis was historically regarded as an additional criterion, but this is no longer the case because local fibrosis is now recognized to coexist with emphysema both histologically and at imaging. Emphysema is pathologically classified according to the anatomic area predominantly affected. Emphysema pathology, centrilobular, focal emphysematous destruction that originally affects the center of a secondary pulmonary lobule and, if progressive, can eventually involve the entire lobule. Even if severe, centrilobular emphysema tends to respect the borders of the lobule, which are not destroyed. On CT examinations, Early centrilobular emphysema is characterized by small areas of low attenuation surrounded by normal lung, without clearly defined walls, often with upper lobe predominance. When progressive, larger areas of low attenuation can span several secondary pulmonary lobules. Emphysema pathology, centrilobular. Arrows indicate the centrilobular emphysema. Amigos, you subscribed and liked. Thank you very much. Panlobular diffuse emphysematous destruction across the secondary pulmonary lobule, the structures of which are effaced, sometimes with a lower lobe predominance. On CT exam, panlobular emphysema is characterized by larger and/or diffuse areas of low attenuation, where components of the normal lung architecture, and notably those of the secondary pulmonary lobule, are no longer recognizable. Emphysema pathology, panlobular. Black arrows indicate panlobular emphysema. Emphysema pathology, panlobular. These two patients show panlobular emphysema. Emphysema paraseptal, focal, emphysematous destruction of the distal achinus, typically located near the pleural surface, close to the chest wall, mediastinum, and interlobar fissures. On CT exam, paraseptal emphysema is characterized by foci of low attenuation, separated by intact interlobular septa, thickened by associated mild fibrosis. Architectural distortion is typically absent. Emphysema pathology, paraseptal. Arrows indicate paraseptal emphysema on chest X-ray and CAT scan. Emphysema pathology, paraseptal. Arrows indicate paraseptal emphysema without architectural distortion. Emphysema pathology. In addition to pathologic definition of emphysema, visually defined CT subtypes of emphysema have been described. The terms interstitial emphysema and subcutaneous emphysema are sometimes used to designate abnormal air collections in the pulmonary interstitium and the soft tissue, respectively, as may result from barotrauma. These abnormalities are distinct processes and are not related to the destruction of the lung parenchyma. Empyema pathology. Empyema is a collection of pus in pleural space, most often occurring as a complication of pneumonia or esophageal perforation. Empyema is commonly unilateral. On CT exam, the fluid collection may contain locules of gas, and pleura is thickened and enhances after IV contrast administration. At margins of empyema, the pleura can be seen dividing into its visceral and parietal layers. This is referred to as split pleural sign, which can occasionally help to distinguish an empyema from a parapneumonic effusion or a peripheral lung abscess. Empyema pathology, split pleural sign. Arrows indicate both sides of a pleura. Lateral one is parietal pleura and medial one is visceral pleura. Fibrosis, adjective, fibrotic, pathology. Fibrosis is a general term for a repair mechanism of the lung in which parenchyma is permanently replaced by connective tissue, causing remodeling, architectural distortion, and volume loss. Other CT signs of fibrosis include traction bronchiectasis or bronchial ectasis and potentially honeycombing. Fibrosis can be the result of mechanical, inflammatory, infectious, or iatrogenic damage. It can be focal or diffuse in distribution and is often accompanied by functional impairment. Fibrosis pathology. CAT scan shows bilateral pulmonary fibrosis of idiopathic pulmonary fibrosis patient. A fissure anatomy. A fissure is a structure consisting of two layers of infolded basal pleura that separates the lobes. The left major oblique fissure separates the left upper lobe and left lower lobe. The right minor horizontal fissure separates the right upper lobe and right middle lobe. The right major and oblique fissure separates the right lower lobe from the right upper lobe and right middle lobe. On CT exam, normal fissures are seen as thin and regular lines. Fissure anatomy, minor and major fissures. This is the axial image of CAT scan. White arrow indicates minor fissure. Black arrows indicate major fissures. This is coronal CAT scan. White arrow indicates minor fissure. Black arrows indicate major fissures. This is the right lung sagittal CAT scan. White arrows indicate minor fissure, and black arrows indicate major fissure. Fissure anatomy. Accessory supernumerary fissures, usually separating segments rather than lobes. Adjacent. Developmental variant consisting of a fold of a pleura pulled through lung towards hilum by a non-migrating right posterior cardinal vein, one of embryological precursors of adjacent vein. Because adjacent fissure has two visceral and two parietal layers, it is in fact a pseudo-fissure. Incomplete. Partial absence of a fissure between two lobes. Incomplete fissures allow collateral ventilation between two lobes. Therefore, their detection is relevant, for example, before emphysema treatment with endobronchial occlusive devices. Fissure anatomy, accessory, and incomplete fissure. On your left side, arrows indicate accessory fissure. On your right side, arrows indicate incomplete fissure of right major fissure. Fissure anatomy, adjacent fissure. Arrows indicate adjacent fissure. Ground glass, physiology and pathology. Ground glass refers to an area of increased attenuation that does not completely obscure underlying bronchial and vascular structures. Although historically first described in radiographs, specifics of this term have been defined for CT, and it should only be applied in context of CT. Accurate identification of a ground glass opacity requires thin section CT less than 1.5 mm acquired at full inspiration, preferably reconstructed with a high spatial frequency algorithm and displayed with wide window width. The findings is nonspecific, as ground glass can be caused by any abnormal process below resolution of CT scanner. that does not completely displace alveolar air. For example, partial filling of alveoli by fluid or cellular material, an increase in capillary blood volume, histologic fibrosis, lipidic pattern of adenocarcinoma, or a combination of the above. Ground glass nodule physiology, pathology. Arrows indicate ground glass nodule in left lower lobe. This is adenocarcinoma. Ground glass opacity physiology, pathology. Arrows indicate ground glass opacity. This patient is COVID pneumonia. Ground glass opacity physiology, pathology. Arrows indicate ground glass opacity in the IPF patient. Ground glass opacity. Arrows indicate ground glass opacity of alveolar pneumonia patient. Halo pathology. A halo is a rim of ground glass opacity surrounding a nodule, mass, or consolidation. The presence of a halo is nonspecific, but often reflects local hemorrhage around an infectious or neoplastic lesion. For example, invasive aspergillosis or lipidic tumor growth. For example, primary adenocarcinoma. Halo pathology, angio-invasive aspergillosis. Arrows indicate the halo. Hilum, plural hyla, adjective hyla, anatomy. The hilum is the site at the medial aspect of the lung, which is not covered by visceral pleura, adjacent to the mediastinum, where vessels and bronchi enter and leave the lung. The hilum contains bronchi, arteries, veins, lymphatic vessels, lymph nodes, nerves, and other structures. Hilum anatomy. These two yellow squares indicate hilum. Both sides of hilum, right and left. Left side is a little higher than the right side. Honeycombing pathology. Honeycombing represents destruction of the lung parenchyma with a loss of architecture and well-defined adjacent cystic structures, typically clustered in the subpleural region. The traditional definition requires several layers of cysts, but in current practice, this threshold has been reduced to a single layer of cysts, provided other signs of fibrosis are present. The diameter and wall thickness of the cysts are variable, but their presence is inevitably accompanied by complete effacement of normal lung architecture and usually occurs with other signs of pulmonary fibrosis, including traction bronchioloectasis. Honeycombing pathology. Of note, honeycombing can also exist at the microscopic level and does not necessarily reflect the CT appearance of honeycombing. Care should be exercised when using the term honeycombing, as it implies substantial fibrosis, and the term should only be used if other signs of fibrosis are present. Honeycombing pathology. Arrows indicate the honeycombing. Honeycombing pathology. We are watching the honeycombing in right lower lobe of IPF patients. You quit smoking? Your greatest job of the year. Congratulations. See you soon on part 4.